Well, let's start this session. This session will be also co-chaired by my colleague Miguel Barbosa from Vila-Real, and we have also Professor Carlos Rabassa and Pedro Madeira from IPO Coimbra. Let's start with my dear colleague and friend, Professor Isabel Fernandes, who is going to talk about immunotherapy in bladder cancer.
Good morning to all. First of all, I would like to thank the organization, namely to Dr. Calais, the invitation to be here presenting the evolution of the paradigm in the treatment of advanced urothelial carcinoma. As you will imagine, there will be some overlapping with Dr. Cora's presentation, which is a new challenge because she's a well-known mundial expert in the area. But I will try to synthesize what is changing in our clinical practice. And all you know the epidemiology, that is the second urologic neoplasm. There are 413,000 new cases a year. It's more frequent in men, and the histology in 92% of the cases is of urothelial carcinoma. And in here, we see that things are changing and will change much more in the next few years with a lot of trials with immunotherapy, namely combined immunotherapy such as durvalumab with tremelimumab, which is an anti-CTLA-4 and anti-PD-L1 drug. And you have immunotherapy with chemotherapy and with other biological agents. And what we have until now, or until 2 years ago, in the metastatic setting, or we had a clinical trial that we can put the patients, or we had only palliative chemotherapy. When we think in Portugal, the majority of our centers don't have clinical trials, and even when we have clinical trials, they are very few, with few places to put patients, and we have some difficulties. We are improving, but we still have some difficulty of getting this kind of research in our centers. So the patients, in the majority of the cases, did palliative chemotherapy. And the chemotherapy that was already, between yesterday and today, was already extensively named with MVAC and cisplatin gemcitabine. We have the luck to have two of the experts that were the main researchers of these two chemotherapies today in this room, and some other chemotherapies that can also can be done in second and third lines if we had anything else. But now we have new treatment options with immunotherapy, checkpoint inhibitors. In here you can see some of them. We have the anti-PD-L1 with the Tezo, Durva, and the Velo, and the PD-1 with the Nivo and pembrolizumab, the ones that are already approved. There are others that are being investigated, and some of the anti-CTLA-4 are being tested with some of the PD-L1. These are the checkpoint inhibitors that are already licensed in metastatic setting, and it's namely these three. This, which is atezolizumab and pembrolizumab, are the only ones that have phase 3 trials, and you will see these trials a little bit in the next slides. So when we think on atezolizumab, was the first one approved based on a phase 2 trial. Theoretically, the anti-PD-L1 drugs have some protections against autoimmunity, but in practice, we don't see this so clearly in the trials that have already been published. Maybe nivolumab is an exception, as we will see. And the first trial was EM Vigor 210. You already saw this before. This is a trial with 2 arms. In the first cohort was the patients that are not eligible for cisplatin. And this was the first time that we think maybe, if they are not eligible, maybe they can do immunotherapy in the first line. And what we see is that besides the PD-L1 expression, there wasn't many changes in the responses. And the responders in this trial included patients with poor prognostic factors and more than 80 years old. And you can see here one thing that we, until now, we didn't have. At a median overall survival of 14.8 months, and at 1 year, there was 57% of patients alive. And when we see the overall survival, the PD-L1 status in here didn't matter. The safety is quite well tolerated, but the things that for us that is more worrying is the hepatitis, myocarditis, colitis, and we need to be very attentive to this, because if the patient starts with these autoimmune reactions or secondary effects, we need to give it corticotherapy or even other kind of immunosuppressors, such as rituximab, mycophenolate of mofetil, or others. And in this trial, what we saw in the majority of the patients was grade 1 and 2. But there was a severe sepsis with death of the patient. So it's not completely innocuous. When we go to the cohort 2, we saw that in here, yes, the progression-free survival and overall survival were associated with the immunohistochemical PD-L1 status. So why we have that different? Maybe we don't know yet, but maybe in the future, and maybe we can select the patients. But when we came to the phase 3 trial, the phase 3 trial was negative. And was negative, but the atezolizumab was approved even so because of the overall response rates. There were a committee. This was presented in ASCO GU this year. There were a meeting when several researchers joined and decided that based on the overall response rates and durable responses, that was consistent with the phase 2 trial and with the other trials of immunotherapy, the drug is yet approved by FDA and EMA, but the phase 3 trial was negative, and I think it has some importance because we don't know why this happened. What about pembrolizumab? Pembrolizumab is an anti-PD-1 drug, and the phase 3 trial, which was Keynote 45, randomized patients to pembrolizumab versus other kind of chemotherapy. And what we see in this trial is not so much the improvement in progression-free survival, but in overall survival there was a statistical significant difference that we didn't see in here. But pembro seems to be better in terms of overall survival compared with the chemotherapy arm. And these results, now there was, you all already saw this a few minutes ago, presented by Dr. Cora. There was, this is consistent during the time. And what about the security? I always mention the security of the drugs because we are clinicians and we need to see what the things we are going to do to our patients will have some impact in their quality of life. For instance, yesterday, Dr. Elizabeth showed one interesting phase 1 trial with sunitinib and immunotherapy, and the results were quite fantastic. But the secondary effects were so huge in renal cancer, but maybe we won't do it. So in here, it's consistent with the atezolizumab security trial. What we see in here is the majority of adverse events were grade 1 or 2 without worsening the renal function in patients with this previous condition. We in pembrolizumab have already a phase 2 trial in first line. In first line for ineligible patients for chemotherapy. This is similar to the cohort I showed you in the EM Vigor 210. And in here, in this trial, we saw that there were 58% with tumor reduction in first line setting, and with durable responses, which is consistent with the other trial. What about nivolumab? Nivolumab was already presented today also, and this is a phase 1-2 trial in which the first time with nivolumab was tested, and based on this, the drug was approved by FDA and EMA. As you can see, the curves are very similar to the others that I show you in the other phase 2 trials, with good overall survivals around 50%, in this case 45.6% at 1 month. And in the phase 2 trial with 270 patients, we saw that the tumor response was observed regardless the PD-L1 status. So we don't have yet good biomarker for these drugs that are now being tested in several clinical trials. More than that, the cutoff are not the same in all the trials, and the antibody is not the same. So how we will do it in our clinical practice? Maybe we can discuss that later. And with nivolumab, we also see durable responses with some patients that go more than 32 months, that you can see in here. And in here, you can see that the curves overlap on each other. And the median overall survival compares the median of survival in the nivolumab-treated patients compares favorably with historical controls. So it seems to be a good option. But what about security? I don't know why this happened in this trial. But in here we had 3 grade 5 events. One that due to pneumonitis, one to acute respiratory failure, and one that due to cardiovascular failure. And this is, I think it's very important because sometimes we don't think, but we know already that in the heart we have PD-1 receptors. So when we give this drug, the probability of a cardiac event is it can occur because since we block the protection of the heart against autoimmunity, it's probably that the autoantibodies will react against the heart, and we can have myocarditis associated with immunotherapy or even pericarditis. But myocarditis is more important, and it's more frequent in these kind of drugs. What about the molecular subtype? Dr. Correll already told you that luminol-2 is the one that responds better to the immunotherapy, but we have some complete responses even in the cluster 3 and in cluster 1 in this specific trial with nivolumab. Finally, durvalumab, what we have? We have a phase 1 trial that already shows us that we can have a very good response, but mainly in the PD-L1 population. So in this drug specifically, it seems that the status of PD-L1 can be important. For other diseases are not urothelial cancer, we have drugs that are being approved with the obligation of doing the PD-L1 or not, and other drugs that are being approved without this consideration because of these different results in the different trials. The safety is similar to the others without, with the majority of the patients with grade 1 and 2 adverse events. And we are waiting the Danube trial that is a combined, combined treatment with durvalumab and tremelimumab. Finally, the avelumab, the same results, see? It's around, at 1 year, it's around 50%, in this case 54.3%, with not very good response in the progression-free survival, and in this case, the PD-L1 status is also important. This you already saw it. There are several trials that are ongoing, and we need to see the results of this to decide which is the best option. So, at the moment, we have, in the advanced urothelial carcinoma, we have the poor prognosis. The gold standard is still the platinum-based chemotherapy with MVAC or cisplatin gemcitabine. Immunotherapy, it's a new paradigm, namely with the checkpoint inhibitors. All 5 agents achieve durable remissions and can be considered even in first line for the patients that are not eligible for cisplatin-based chemotherapy. Pembrolizumab is the only agent that has a statistical significant phase 3 trial, and PD-L1 is not yet completely. We don't have yet information to do it in all these agents. Maybe we need other biomarkers to define in which drug or in which treatment we will put our patients. Maybe we can discuss other things. And what about the different drugs? We have 5, Atezo, Pembro, Durva, Avelo, Nivo. Which one we will do it? Based on price, based on other things? I think this is it's a question that needs to be answered, because I think it's the second time in oncology that we have these kind of things. We had these with abiraterone and enzalutamide in prostate cancer, but now we have 5 drugs, and we don't know which is the best one for the patients. Maybe we won't have the response in the next year. Maybe Cora can help us. I don't know if you have some answer to this or someone in the audience, but there are a lot of questions that needs to be answered. Which patients, which drug is the best, which drug to do in first line or in second line, and which will be the best sequence for our patients. Thank you very much. I don't know if you have any questions.
I think we'll do the discussion after the second presentation. Thank you very much for the invitation to be here. I would specifically thank Dr. Calais for the kind invitation to be here. I'm very proud to introduce the next speaker. His name is Dr. Angel Aranz. He comes from Hospital Gregorio Marañón. He's the head of the genitourinary unit. And he's going to talk about the clinical experience with immunotherapy in invasive bladder cancer. Thank you.
Thank you very much. Good morning, and thank you to Dr. Calais for the kind invitation to be here. It's my pleasure to be once again in Portugal in this meeting, this very interesting meeting. And it's not easy to say something different after all the discussion we have had this morning and the previous presentation, but what I'm going to do in my talk is to try to put all this concept in context from a practical clinical point of view, just to try to take one message for the everyday practice. Let me remind what is the line of the treatment in a patient with bladder cancer, just to put my talk in context. Patient will start with a non-muscle invasive bladder cancer, then he can go to muscle invasive bladder cancer, which is treated with bladder preservation in selected patients, but most of them have a radical cystectomy with perioperative chemotherapy. Patients with metastatic, either at the diagnosis, either a diagnosis or after the evolution of the disease, are usually treated with cisplatin-based chemotherapy if they are eligible for chemotherapy, or with carboplatin-based chemotherapy if they are not, or even with palliative care in near to 50% of the cases in this subgroup of patients who are unfit for cisplatin. Maintenance is not considered as a standard at the moment, but it can be considered in the context of clinical trials. And for metastatic second line, we give usually chemotherapy, depending if the patient has a free interval longer than 12 months, 6 months sometimes, depending on the authors. We repeat platinum-based chemotherapy in this case, or we give vinflurin or taxanes as a standard for this situation. The two more important things that have happened in the last 5 years are we have now a lot of knowledge about the biology of the bladder cancer, which allow us to classify intrinsic subtypes or know many things about tumoral burden mutation rate, about genetic change, about many prognostic factors, and even genetic signatures that allow us to know something about prognosis and biology of this tumor. And the other thing is the appearance of immunotherapy in the treatment of this tumor, and immunotherapy has spread along all the stages of the bladder cancer, and now we have, in one way or another, immunotherapy everywhere in bladder cancer in the context of clinical trials in localized bladder cancer, in metastatic, in maintenance, perioperative, or in second and first line. So we have to learn immunotherapy, yes or yes. We don't have other way to go ahead. I'm going to try to say something about this subgroup of patients, unfit patients for cisplatin in first line, and these other subgroups, the patients who relapse after a platinum-free interval of less than 12 months. Second line. Let's show this case just as an example of what immunotherapy can do in these patients. This is my best patients, the best, just to discuss. He's a male, 62 years old, who had a radical cystectomy in July 14 with lymphadenectomy. He was a PT2 and 2. And just after surgery, he was diagnosed of massive pelvic lymphadenopathies. He was treated with chemotherapy, and after a platinum-free interval of 5 months, he has a new recurrence of the disease, and he was offered to participate in the Keynote 045. He received pembrolizumab. He was randomized, and he received pembrolizumab. He has no relevant toxicities. He achieved complete remission, and after 2 years, the protocol said that the patient has to go off the treatment just to follow up. And then after 5 months, he again had a relapse, and the protocol allowed to restart pembrolizumab, and that was what we done after all this previous background. And the patient is, I don't know what happened, but the patient is again responding to the treatment, and here should be a warning saying, this is my best patient, not all the patients are like this. Sorry. Oh, yes, it comes. Discussion. What we have now in second line for our patients? We have chemotherapy, but the efficacy of chemotherapy in second line, monotherapy with vinflunine or taxanes, achieve around 10% of response. The PFS is 2 months, 3 months, and the median overall survival is around 7 months. So these patients go quite better than the standard. And this is the expected overall survival in the randomized trial that compared vinflunine with placebo. And here can you see 6.9 months of overall survival. This is the standard for reference to be compared with in clinical trials with other studies. We have clinical prognostic factors that allow us to classify and make prognosis about every patient. And the best subgroup of patients can achieve around 14 months, median overall survival of 14 months. With this classification, which is the Belmont classification that takes into account only the 3 first prognostic factors, and this other Soundpout classification taken into account also the platinum-free interval, considering less than 3 months like a bad prognostic factor, and the classification is more or less the same. A good subgroup of 14, 7, 3.5 more or less, and 1.5. This is the median overall, the expected median overall survival in second line. We know many things now about molecular and genetic prognostic factors, but we don't know yet how to put one and another clinical and molecular prognostic factor in a same classification. So we have to take in our mind that they exist, but we don't know how to correlate one with another at the moment. Immune checkpoints inhibitors have come on in this setting, and this is the slide we have seen many times in this morning, with the 5 drugs approved by the FDA, but the 5 drugs are not the same. Avelumab and durvalumab were approved in the basis of phase 1 trials, and not as every phase 1 trial, they have enriched population in some way or another. For example, in durvalumab, the durvalumab population was enriched in patients with positive PD-L1. The avelumab population was analyzed only if the patients had more than 6 months of follow-up, just to evaluate response after 6 months. So they are typical studies of phase 1 with an enriched population that only can give us some kind of results about efficacy, but not very strong results. Anyway, they achieve around 20%, less than 20% of response rate. That is twice their expected response with the standard chemotherapy. Atezo and Nivo were approved mainly in the basis of phase 2 results, because nivolumab made a phase 2 study to compare the response rate against the control response rate from the previous studies with chemotherapy, which was 10%. And they developed a study just to test the hypothesis, and they achieved good results, 20% of response rate, that allow the FDA to approve the drug. Atezo have also phase 1, has a phase 2, and also has a phase 3, but as you know, and has been discussed this morning, the phase 3 trial was negative, so its approval was based mainly in the result of the phase 2, and response rate was 23%. More or less, all these drugs achieve around 20% of response rate, which is quite good. And Pembro has a phase 3, in which updated response rate in the last follow-up was 21.1%, and it has also results in overall survival. So let's go to this study to see some data more in depth. With a median follow-up of 27.7 months, which is good follow-up, these are the results. Objective response rates 21%, with durable duration of response better than chemotherapy. progression-free survival is not an objective of these studies because of the immunotherapy needs time to act. But anyway, median progression-free survival was 2-3 months. There was no differentiation between both arms, but in the long term, we can see that there is a stable increase in overall, in progression-free survival along time. So there is no differences in median overall survival, but some patients achieve long responses. Maybe my patient was in this part of the cure, and this is stable and along many months, at least 30 months. This is one of my patients. But the main result of the study was overall survival, which was achieved in the long-term follow-up. Median overall survival were 10.3, 7.3, with a hazard ratio of 0.7, and a stable increase around 10% along the time in overall survival, which are very good results, taking into account that the study was closed in an interim analysis, and then 60% of the patients have received an PD-L1 or PD-1 inhibitor in clinical trials or in standard practice as part of the crossover. So this is something that we have to take into account when see and interpret the curves. And this benefit was seen in all the subgroups that were analyzed, including different percentage of positivity in PD-L1, including local clinical factors, the drugs that were used as competitors. So we have to ask, and that was part of the discussion this morning, it is worth to administer this drug, how much it costs, is cheaper, is cheap, is expensive. In this study, they do a Markov model to compare the cost and effectiveness of pembrolizumab compared with those of the chemotherapy arm. This is the Markov model, and was developed taking into account drug cost in US, UK, Canada, and Australia. And these results need to be compared, taking into account that not everywhere is the same and have the same concept of willingness to pay. How much are you willing to pay for what? And the way to standardize this question is to calculate the QALYs, the gain of years adjusted by the quality of life of these years gained, and how much they cost, and how much every country is willing to pay for this year adjusted to the quality of life. And the willingness to pay is not the same in US, in Canada, in UK, and in Australia, even in Portugal, in Spain, in other parts of Europe. So this is a political question more than a scientific question. The thing is that pembrolizumab achieved 37 years gain adjusted by quality of life. Years that the patients say that it was to be lived. This is the traduction of this concept. But according to the politics decisions, it may be cost effective in US or no, depending on how every country is willing to pay. So this is the solution to the question this morning. This is the benefit. It is enough for you or it is not. If that's the problem, probably we have to know if there are any patients more probably to benefit from this treatment. And in the InVigor study, the Atezo study, the phase 2 study, they have classified patients according to clinical prognostic factors, and they have classified, they have given us this very useful tool for the future they identified these 6 factors as prognostic for overall survival for the use of checkpoint inhibitors after cisplatin-based chemotherapy. This subgroup of patients. And the clinical prognostic factors were ECOG, liver metastasis, platelets, neutrophil to lymphocyte ratio, LDH, and anemia. We have all in our clinic, we have these prognostic factors, so it's easy to use this classification. PD-L1 was statistically significant when adjusted for these factors, but didn't improve the statistic that measures the efficacy of the model. So they were let apart. And using these 6 prognostic factors with 1, 2, 3, or more than 3 prognostic factors, patients are classified and they can achieve at least 2 years of median overall survival, less than around 6-12 months in this intermediate subgroup, or only 3 months in the poor risk. So probably there are patients that are not going to get benefit from this treatment. So this is a very useful tool. It has been presented this year a few weeks ago in the genitourinary cancer symposium. And I like very much this classification. What about the unfit patients in first line? The other near approval we are going to have in the next months. Well, here's another case, a patient with 74 years old, myocardial infarction and mild chronic renal failure. This is very common in patients with cystectomy and smokers and our population of patients. In January last year, he has a hematuria and he started to study. A CT scan showed pelvic retroperitoneal lymphadenopathies, bone scan was negative, and this patient was offered to enter in the Keynote 361. This is a randomized study in first line, comparing carbo, gem, or cisgem. This is for unfit patients, this is for fit patients, eligible for cisplatin and eligible for cisplatin, versus pembrolizumab or the combination of both, and he was allocated in the pembro arm. After 2 months of treatment, the CT scan was worse. What that means? This is a pseudo progression or this is a true progression? We can discuss about that later, but we decided at this moment continue on treatment, and the patient have a partial response important partial response after a few more months. So it's a patient with now has a PFS and overall survival of more than 11 months. With this critical point in the decision, and we are going to go back over this topic in this slide. What can we discuss about that? First of all, we have to say that until now, about 50% of the patients, because of comorbidities, are not fit enough to receive chemotherapy, and they receive only best supportive care. So this is not only because of poor condition in terms of ECOG, it is about, because of a lot of comorbidities that sometimes tell us this patient is not fit enough to receive chemotherapy, and they didn't receive anything. So only about half received chemotherapy. In 2011, there was a working group that made this consensus of what are the criteria for considering a patient unfit for chemotherapy. And it has to do with ECOG of 2, creatinine clearance less than 60 milliliter minutes, hearing loss because of the ototoxicity of cisplatin, peripheral neuropathy because of neuropathy of cisplatin, and heart failure, New York Heart Association class 3, because of cisplatin needs to be administered with a lot of intravenous fluid. And our treatment options for these patients are best supportive care, carboplatin-based combination, or taxanes or gemcitabine. And there was not any main protocol to treat this patient until the EORTC made the study, that was published 6 years ago, in which patients were randomized to carboplatin and gemcitabine or this other combination in patients with ECOG-2 and/or an impaired renal function. Here are the results. Median PFS 4-5 months. Median overall survival 8-9 months. So worse overall survival than the population who are treated with cisplatin chemotherapy. And about 9% of severe acute toxicity, that is a term for very severe acute toxicity. Thrombocytopenia grade 4, sepsis, toxic death. But grade 3-4 toxicity is quite common in this population. About 50% of patients have grade 3-4 toxicity. And here are the overall survival curves with no main differences between both treatments, and showing that patients with 1, 2, or 3 1, 2, or 3 comorbidities of this classification go worse. The more factors, the worse overall survival, and the same with the violin risk group, depending on the patient has no 1 or 2 prognostic factor, which is visceral hepatic metastasis and ECOG 1 or 2. The study keynote, we have seen this study several times along the morning, was designed to answer the endpoint of overall survival. They included 350 patients because they also wanted to look for a cut point to consider positive or negative, combined positive score of PD-L1 positive that the company developed. And as you can see in this keynote study, the important things are what are the characteristics of the population. And you can see here that around 50% of patients are more than 75 years. 50% of patients have renal dysfunction. ECOG-2 were 32% patients, and visceral disease was present in 85%. So it's a very, very bad population of patients. And they had a high overall response rate in this population that increased with longer follow-up, because response appeared not at the beginning, like in my patient that had a pseudo-progression, but they can appear along the time because the immune system needs time to work. So we have to be aware about putting the patient off the treatment just by a little enlargement of a lymphadenopathy. But sometimes it is a true progression, so it's not very easy sometimes to decide what is the situation. Anyway, what is important is that in this population of patients, and this has been also presented a few weeks ago in the ASCO GU symposium, this 29% of response rate is very constant in all the subpopulation that we are talking about. This is the unfit patients. Age more than 75, age more than 65, 75, 29, 27, age more than 60, and ECOG status 2, 29, age more than 75, 75, and ECOG performance status 2, 32%. So it is very constant along the different combination of prognostic or comorbidities or situations that classify the patient as unfit for cisplatin. And this is a quick response. Median time to response is only 2 months. It's durable. 82% have responses lasting more than 6 months, and remind that median overall survival in this population is about 7 months, 6-7 months. So durable response lasting more than 6 months is important, and 82% have this of responses have this characteristic. And it's not very toxic. Remind the toxicity of chemotherapy in my previous slide, because grade 4, 3, 5 are around 1-2%. And anyway, we have to be aware about this grade 3, 4 secondary effect typical of immunotherapy that sometimes are very severe and sometimes can lead the patient to the death. So it's not very common, but there are toxicities. The InVigor, is 210, is very similar in the design. Population is the same, is more or less in one way or another a bad population, the same as in the previous study. And the results, this study was officially negative because they tried to achieve an overall response rate above 10%, like the historical control, after a median follow-up of 8 months, more or less. And this first analysis was negative because the lower part of the confidence interval was below 10. But because response appeared with the time, a reanalysis after a median follow-up of 17 months achieved the objective in the study, and overall response rate was 88%. So this is, again, we are playing with the concept of when do we have to evaluate response. This is also quick, this is also durable, median has been not reached, and even in the study, and in the previous study, these results are achieved despite, this is 1.1, who are not very good way to evaluate immunotherapy response, because these pseudo-progressions or initial progressions are considered sometimes progressive disease and don't count as response. However, in the new iRECIST criteria, if after one initial progression you achieve a stabilization response or even complete response, the response is considered complete response, partial response, or whatever. So using iRECIST, probably this response rate in both studies could be greater. Here are the data on survival that has been commented. And this is the table of future trials, only one closed, the Danube study, comparing Durva-Treme and this combination. Two studies comparing Pembro-Atezo with chemotherapy. They are still recruiting patients, and they include eligible and ineligible patients, both. So this we are going to have good information coming from phase 3 trials from in the coming months. This is the Bristol study with nivolumab and ipilimumab. If we have another a trial also with maintenance with avelumab versus placebo in patients who have achieved a response with standard chemotherapy. This is what I told you previously with iRECIST. We have to learn if you used immunotherapy in your clinical practice, you have to learn and study and integrate. It's not difficult, but it's hard to read the article, but we have to do. The new iRECIST criteria has been published last year, and they collect all these problems and they make the definition of what is a response, what is a progression, pseudo-progression, confirmed progression. All these concepts are very well explained in this article, and they explain also why and how patients go to the line of the immunotherapy treatment, progressing sometimes initially, then having response. These kind of things are very well explained in the article. And the other thing you have to know is to be used to identify and treat toxicities, because they are not very common, but they exist. And sometimes are very, very, very difficult to treat, and sometimes can cause the death of the patient. There are guidelines coming from ESMO and ASCO, very good guidelines that help us to identify and treat these patients. And there are also this paper from the Immunotherapy Cancer Society. Yeah, and I have selected 3 images just for illustrate the concept. Toxicity is worse with anti-CTLA-4 than with anti-PD-L1 or PD-1. This is the first idea. The second idea is the pattern of toxicity is not the same as with chemotherapy. In chemotherapy, we have the acute phase in which chemotherapy is given and toxicity appears, and then when you finish chemotherapy, the patients recover from the toxicity. But with immunotherapy, the pattern is different, because toxicities can appear along the time, depending what kind of toxicities. And this is the curve, the timeline of these toxicities, how they appear more or less along the time. Initially, the earlier manifestations are those related with the skin, then those related to intestine and diarrhea and these kind of things. Then endocrinopathies, hypophysitis, and this severe liver toxicity that can sometimes kill the patient. And this is my last slide. So immunotherapy is here. We have to be used to manage and deal with it. We have to study all kind of things, and we have to wait for the results of these studies that sure are going to give us more answers. And that's all. Thank you very much for your attention.
Thank you very much, Dr. Arendts. I will ask you to sit down here. Isabel, come here, please. I will ask some... Hi, Francisco. Sorry. Please. Please. I will ask some brief comments from Dr. Rabassa and Dr. Pedro Madeira, if you want, and then we'll have an open discussion from the audience, if you want, please.
So, well, I'm a neurologist, so as you can understand, as a neurologist, I'm feeling a little bit lost with all these drugs, and between medical oncologists. It is amazing how they can memorize all these names. It's very difficult for me, very confusing. However, well, I have to confess that a new paradigm in the treatment of this kind of patients. It's new. The last 20 or 30 years was, well, very, there wasn't any change. But this new paradigm brings some doubts for me as a neurologist. So I see that we need really new biological markers and to introduce genomics in these patients, because the expression of PD-1 or PD-L1 is not a sign of answer to these kind of drugs. The other point is that we have to study, to have more studies about joining drugs and making treatments with association of different kinds of drugs. I know that there are some studies going on, but we still don't have any answer. And then, well, the toxicity of these drugs is not so low as we could expect, we neurologists. So I think it's amazing for us, and it's opening a big door but at the same time, well, a big confusion in our minds. That's, well, my comments. Well, I have two answers, but I can do it later, please. Okay.
Yeah, I just want to emphasize the immune-related adverse events. So, as we see, those drugs, they are safe, but when there is adverse events, they can be catastrophic. And as Professor Elizabeth said yesterday, I think that family doctors, and mainly in Portugal, perhaps emergency room doctors, must be aware of this kind of toxicity. And I think that our patients should be well informed, and they should immediately contact the medical oncologist to deal with that adverse events. Of course, we have to have in our desktop the ESMO guidelines. They are very important, and with them, I think we, as medical oncologists, we can deal correctly with that adverse events. I have questions for José and Isabel. Do you think, anyway, these immune-related adverse events are predictive of response for same patients, or what is your feeling about that?
I don't think so, no. I haven't seen any clear relationship between toxicity and well, I know that with TKI in renal cancer, yes. There is a relation, but I think it's not the same scenario, no. I don't think so. So if a patient has severe toxicity, there is no reason to go on and keep him on treatment just because there is a higher possibility of achieving a response. No, I couldn't say that. But we don't know anyway.
Okay.
Well, I think we don't know it yet because the trials are ongoing and the majority of the approvals, as you saw, was based on phase 2 trials. We have a clinical practice that is only our clinical practice and not we can extrapolate to other things. And until now, the majority of the patients that we have in immunotherapy, they are in clinical trials in our center. So we don't have so much experience outside the clinical trials because we not even know if when we came to the global of the population, if the adverse events are going to be the same or they are going to be worse because everyone knows that the patients that are in the clinical trials are very selected patients. So we need to know more about that. I have a patient, for example, that had a kind of myositis and is the best patient I have. He's going on atezolizumab for more than 2 years now. And he will change to Imbrel because of that. But this is one case, and in every case there are an exception. So we still don't, I think we don't know it yet. In fact, I don't know if the person that are in here that have more experience with this kind of drugs, such as Dr. Korer, have another point of view or something to add to that.
As I work in Italy, all of my patients are in clinical trials as well. There are very few patients can afford to buy these drugs. The things that have scared me the most have been when they develop lung disease, and I think it's very important to be aware when patients have lung disease to stop the treatment and not keep treating through that, because patients can die from that. I told you about the woman with colitis who has a complete response, and she's actually quite fine now, bringing me chocolates, even though she wanted to sue for money. But you know, they're just individual cases that I don't think any of us have a big enough experience, or any of the companies have looked in, you know, in these 1,000 patients, what happened, and we don't have enough to say anything. To me, whether or not they have a response doesn't seem to be correlated with side effects, and I think that almost everybody has some kind of side effect. I've seen a little bit of a side effect in every one of them. You know, when you have these trials with placebo, you know who's on placebo and who's on active drug. So they all have something, weakness or diarrhea or something. But those are not the side effects we worry about. I worry most about when they have important lung disease or intractable diarrhea and colitis, things like that. They can have apophysitis. We need to work with our endocrinologists and learn how to treat that as well.
Well, I'd like to make a question mainly for the medical oncologists. Do you believe that this kind of treatment will become a first-line one before cisplatin-based treatment in the next future, the near next future, or not?
I think for the ineligible for cisplatin or for chemotherapy, of course, it's already there. But for the others, I don't know, because we know that there are some patients that don't respond to immunotherapy. And the majority of the persons respond to chemotherapy, even with some toxicities. So I think we need more information about that, and we need to wait and to be careful. Because, for instance, if you go to a private hospital in Portugal with an insurance, and participated by the insurance, you paid $8,000. And the combined immunotherapy is already there. And it will be very difficult for us to pay all this. So. And this is one problem, and the other is we don't have evidence. So if you don't have a real strong evidence, that is better for our patient, because when you are in the state, we have some limitations, but we try to give the best thing for our patients. If you don't have evidence, we need to be careful, because you are going to give toxicity without efficacy. We need more information about this kind of.
First of all, I'm sorry for not being here in the beginning of the session. I would like to ask a question for the panel. What is the relationship between these immunomodulators and surgery? Is it safe to have surgery during treatment, or do we have to stop some days, weeks before doing surgery? And what about an emergency surgery? Anyone has experience with this?
It's an individual case. It was for this week. He was in a clinical trial, and at the 13th cycle, he had a bladder rupture. And of course, it was an emergency, so he was submitted to surgery. I don't know how, but we were able to put him in United Care for after the surgery, and he's quite well. But that's what I have, one case. I don't know if there is more evidence, but for me, if I can stop and do the surgery, I would prefer to do that.
Yes, I've noticed that Dr. Arranz put in the question to the future about using immunotherapy in an adjuvant setting or in a perioperative setting, okay, but not in a neoadjuvant setting. Why not?
Three questions. First, your last question. In the operative setting, there are clinical trials ongoing. The design is, let me think, neoadjuvant chemotherapy, followed by surgery, and then if there is residual disease, massively invasive residual disease, patients can be randomized to follow-up or checkpoint inhibitors. This is a good scenario for me, because the standard after neoadjuvant chemotherapy is doing nothing, just follow-up. After surgery, there is nothing that has demonstrated benefit in this population of patients. This trial also allows patients to be randomized without neoadjuvant chemotherapy, just radical cystectomy, and they are randomized to nothing, placebo or checkpoint inhibitors. I'm not sure about the opportunity of this randomization, because I'm not sure that the standard in this situation is placebo. So, but anyway, the protocols allow both situations. I think more patients are coming into the trials starting from the adjuvant chemotherapy, and they are going to give us the answer 1 year, 2 years, I don't know. But it is a very, very interesting scenario. And there are also data of intrinsic subtypes of patients according to the molecular classification that are more probably have a higher probability of benefit from immunotherapy, depending of the particular subtypes or subtype of intrinsic subtype.
It's a little different than the situation with the tyrosine kinase inhibitors and doing renal surgery. The half-life is much longer with these drugs. The half-life is like between 21 days and 25 days, depending on atezolizumab, pembrolizumab. So I don't think we have most of these studies were done in patients with metastatic disease. They're not anti-angiogenic, so I don't really see why it should be a problem to do surgery. But these drugs do hang around for a much longer time than the other kind of drugs that we've used prior to surgery. So I think that may have some effect. But in theory, they should help the immune system. So I don't see why it should be a negative thing to have if they have to have surgery. I don't have any data though.
I don't have any data also, but there are a question in there.
You know, I think an important thing to remember is from the history of chemotherapy. And if you think back 20, 30 years when we used drugs like doxorubicin and bleomycin, it was about 5 to 7 years before we recognized the very significant spectrum of late toxicity. So for bleomycin, we learned late that smokers had all sorts of problems, that the PO2 in surgery with people who were smokers and who had bleomycin was actually lethally dangerous. And the amount of time that we've had with this whole group of drugs is relatively short, and there hasn't been any emphasis on late toxicity reporting. It's not in the interests of the pharmaceutical companies to look for problems before they get their registration. And so I think we just need to be a little careful in comparing the impact of chemotherapy or cytotoxic chemotherapy versus immunotherapeutics. I'm not implying that we shouldn't make progress. Of course I think we should, but I think we should listen to Isabel's comments. You know, this is pretty early, and we don't have robust late data. You know, Matt Galsky's consensus panel made a mistake, and they defined a creatinine clearance of less than 60 as being renal failure, and that's okay. And we're using that as a criterion for entry into these studies. If you remember the case we talked about yesterday, one of the urologists made a tremendously important point, which was in a neoadjuvant case. We had a creatinine of 155, and he said, well, the first thing I would do is stick in a stent. That isn't part of the consensus statement. So there are a whole bunch of patients that we are pushing as cisplatin ineligible into these new immunotherapeutic drugs, where all you have to do is pop a little stent in and the creatinine has a pretty good chance of coming down. As Cora said a little while ago in the previous discussion, you know, these patients, some of them are curable with conventional treatment. So I'm not suggesting we shouldn't make progress. I'm just saying we should be watching what we do and looking for an adequate comparison of late toxicity and the criteria of entry into the studies that we're doing.
I agree, again, 100% with what Derek said. And for me, the creatinine clearance of 60 is not cisplatin ineligible. I know that's what's been used and defined in all the criteria and all, but you can treat patients with 50, you can split the dose into 2, and we do that all the time. I wouldn't not treat someone because they have a 50 or 59 creatinine clearance and say you're cisplatin ineligible. And that's been a sort of a consensus that that's ineligible. And I think that what Derek is saying to try and see what you can do about it, but even if you can't do anything about it, think about splitting the dose in 2 and giving a lot of hydration, even in the outpatient setting, can be done.
Are there any questions more, please? Yes.
Just an additional comment about that is that we have to wait the results of the 2 randomized trial that stratified patients, ineligible patients for cisplatin, eligible patients, and they randomized then to one of the three arms that are immunotherapy, the combination of chemotherapy. So the results we have until now are results coming from phase 2 studies, very big phase 2 studies, because one of them is 300 patients, but phase 2 studies. So we have the approval, we can use it, but we have to wait and the phase 3 trial to have definite conclusions about that.
We are just in time. We are going to finish. Thank you all. Have a nice time.